If your feet burn more when you lie down at night, when you are finally still, finally resting, finally doing nothing, that is not a coincidence. That is your nervous system telling you something specific. And it is something most neuropathy patients are never told. Tonight, by the end of this video, you will understand exactly why that happens. And more importantly, you will have a concrete protocol to begin changing it. What I want to talk about today is not medication. It is the physical environment the nerve lives in, and how deliberately changing that environment through specific, targeted movement can do something that pharmacological management alone cannot. I am Dr. Hameed Ullah Shaheen, and in my clinical work, I see neuropathy patients who have been living with burning, numbness, and that crawling sensation in their feet for years, often on medication that takes the edge off, but never quite resolves it. These are not generic stretches. Every movement I am going to share has a specific anatomical reason behind it. I want you to understand why each one works, because patients who understand the mechanism are the ones who actually do the exercises consistently. And consistency with neuropathy is everything. The framework before we begin. Let me give you a mental model that will make everything else make sense. Your peripheral nerves, the ones carrying signals between your spinal cord and your feet, are not just electrical wires. They are living tissue. They have their own blood supply called the vasa nervorum. They require oxygen. They require physical space to move through surrounding tissue. They require mechanical stimulation to maintain their sensitivity. When neuropathy develops, whether from diabetes, chemotherapy, idiopathic causes, or chronic compression, what happens is a slow degradation of that environment. The nerve's blood supply becomes compromised. The surrounding tissue stiffens and in some cases traps the nerve. The sensory endings in the foot stop receiving the variety of input they need to stay functional. The result is that paradox you know so well: burning pain and deadness simultaneously. The nerve is not broken in a simple way. It is oscillating between understimulation and hypersensitivity because its environment has deteriorated. Everything I am going to show you today targets one or more layers of that environment. Movement 1. The arch activation. Most people, when they think about foot exercises, think about the ankle or the calf. But inside the foot itself, there are more than 20 small muscles, called the intrinsic muscles, whose job is to maintain the structural architecture of the foot from the inside. These muscles do not move your leg. They do not flex your ankle. What they do is hold the shape of your foot, the arch, the spacing between the metatarsal bones, the positioning of each toe. And that internal shape is the physical housing of your nerve endings. When the intrinsic muscles weaken, which happens reliably with reduced walking, age, and the protective guarding that neuropathy pain causes, the architecture collapses slightly. Nerve endings that were cushioned and supported become exposed to compression with every step. Here is the exercise. Sit in a chair with your bare foot flat on the floor. Without curling your toes, keep them long and relaxed. Try to lift the arch of the foot as if you are trying to create a dome underneath it. The heel stays down. The ball of the foot stays down. Only the middle of the foot rises. Hold for 5 seconds. Lower slowly. 10 repetitions per foot. It will feel strange the first few times. These muscles have not received a direct activation signal in a long time. That strangeness is useful information. It confirms the muscle group has been dormant. 3 weeks of consistent daily practice will change the structural environment your nerve endings live in. Movement 2. Circulation at the ankle. The letter tracing method. Here is the anatomy most neuropathy patients are never shown. On the inner side of your ankle, just behind and below the ankle bone, there is a narrow passage called the tarsal tunnel. Running through this tunnel, alongside tendons and blood vessels, is the tibial nerve, the primary nerve supplying sensation to the entire sole of your foot. Immediately beside it runs the tibial artery, the main blood supply not just to the foot, but to the nerve endings within it. When ankle mobility decreases through reduced activity, stiffness, swelling, or the connective tissue changes that accompany aging, circulation through that tunnel slows. The nerve's own blood supply diminishes, and symptoms in the foot intensify. Not because the nerve has suddenly worsened, but because its oxygen supply has quietly reduced. The solution is comprehensive ankle mobility work, moving the ankle through every plane of motion to pump circulation through that tunnel repeatedly. The most effective way to do this without placing any load through the foot? Sit with one foot lifted slightly off the floor, using only your ankle, not your leg, not your knee. Use your big toe as a pen and trace the letters of the alphabet in the air. Write each letter slowly and as large as you comfortably can. Large letters mean greater range of motion, which means more circulatory pumping through the tarsal tunnel with each movement. One full alphabet per foot, once daily. It takes approximately 3 minutes per foot. The cumulative benefit to the nerve's oxygen environment, done consistently, is significant. This is the movement that directly addresses the nerve pathway going quiet, which is the mechanism behind progressive numbness. Here is the principle. Sensory nerve pathways that are not regularly stimulated do not hold their current level of function. They decline. The nerve endings in your foot that have partially lost sensitivity will continue losing it unless the brain receives regular, varied input through those pathways. Medication can reduce the pain signal. It cannot maintain the sensory pathway. Only stimulation can do that. The protocol. Fold a thick towel twice and place it on the floor beside a wall. Stand on it in bare feet, one hand lightly touching the wall for balance. Slowly shift your weight, heel to ball, side to side, for 60 seconds. The slight unevenness of the folded towel creates varied pressure across the sole that a flat floor cannot provide. As this becomes manageable, progress to a textured bath mat. Then, if available, a shallow tray with smooth dried lentils or rice, something your foot can press gently into while standing. This is a direct adaptation from diabetic neuropathy rehabilitation programs used in specialist centers in South Asia and East Asia. The goal is not discomfort. The goal is variety of sensation, different pressure patterns, different textures, different distributions of load. Each variation sends a slightly different signal pattern through the sensory nerves, maintaining the activity of those pathways actively rather than passively allowing them to deteriorate. Do this once daily. 60 seconds is sufficient. Consistency matters far more than duration. Movement 4. The nerve itself must move. This is the movement that most surprises patients and most general practitioners when they first encounter it. Nerves are not static structures. With every movement your body makes, bending the knee, flexing the ankle, taking a step, the sciatic nerve and its branches slide several centimeters through the surrounding tissue. In a healthy nerve surrounded by mobile tissue, this happens effortlessly and continuously. In a nerve surrounded by inflammation, chronic swelling, or the connective tissue adhesions that develop from prolonged reduced activity, the nerve becomes tethered. It adheres slightly to the tissue around it. When it is then asked to move, it cannot complete its full excursion. The mechanical tension that results disrupts signal transmission in ways that are entirely separate from the fiber damage itself, and that do not respond to medication targeting the fiber. This is called neural tension, or nerve adhesion, and releasing it requires moving the nerve specifically, not just the joints around it. The technique. Sit upright in a firm chair. Slowly straighten one knee until the leg is fully extended in front of you. As you straighten it, simultaneously pull your toes back toward your shin, what we call dorsiflexion. Hold for 3 seconds and notice if you feel a deep pull along the back of the leg or into the foot. Then simultaneously bend the knee and point the toes away from you. Hold for 3 seconds. That alternating sequence, legs straight and toes pulled back, then knee bent and toes pointed, moves the sciatic and tibial nerve through its full path from the lower back to the foot. 10 slow repetitions per side. The sensation should be a tolerable, dull stretch, not sharp, not shooting. If it provokes sharp pain, reduce the range of motion. This is standard practice in peripheral neuropathy physical therapy. It addresses something that structural exercises and sensory stimulation cannot reach. Movement 5. Fine fiber activation at the toe level. The sensory nerve endings most vulnerable to early neuropathy damage are the small fiber nerves, the ones responsible for fine touch sensation in the toes and ball of the foot. They are thinner, less myelinated, and lose function earlier in the disease process than the larger fibers. Maintaining their activity requires direct mechanical stimulation at the nerve ending itself, compression and decompression of the digital nerves running along each toe, repeated rhythmically. 2 practical ways to do this. First, place a small hand towel flat on the floor. Using only your toes, scrunch it toward you, then spread it back out. 10 repetitions per foot. Second, and more demanding, place 5 marbles on the floor beside a small cup. Using only your toes, pick them up one at a time and drop them into the cup. The marble exercise is more specific because each marble requires independent control of individual toes, recruiting more of the intrinsic muscle group and stimulating a wider range of nerve endings simultaneously. It also requires the brain to direct attention precisely, which strengthens the neural pathway between the foot and the motor cortex. Both versions are used in sensory rehabilitation programs. If you can only do one, do the marbles. Preserving the balance system. Neuropathy does not only attack pain and temperature sensation, it attacks proprioception, the sense that tells your brain where your foot is in space without you looking at it. This is what makes neuropathy genuinely dangerous. It is not only the discomfort, it is the quietly increasing fall risk that most patients do not notice until they have already had an incident. The proprioceptive fibers run in the same peripheral nerves as the sensory fibers. They are damaged by the same processes. But here is what rehabilitation programs consistently show. Patients who continue balance training after a neuropathy diagnosis maintain independent, confident walking substantially longer than those who stop. Not because the training reverses nerve damage, but because it forces the nervous system to use its remaining functional pathways more efficiently. Demand preserves function. The progression: stand beside a wall or countertop with your fingertips resting lightly on the surface. Shift your weight fully onto one foot and hold for 10 seconds. Switch sides. As stability improves over days and weeks, reduce contact to fingertips only. Then hover your hand just above the surface, using it only if needed. Then try a folded towel underfoot, an uneven surface that forces the ankle and foot to process more varied sensory information. 2 repetitions per side, daily. This is not about challenging yourself to the point of risk. It is about maintaining the nervous system's engagement with the sensory information it still receives. The moment you stop asking it to work, it works less. Answering the question I opened with. I said at the beginning that burning pain worsening at night is not a coincidence. Let me close that loop. During the day, even a small amount of walking and movement maintains circulation through the tarsal tunnel and the tibial artery. The nerve endings receive their minimal oxygen supply. The sensory pathways receive some input. The nerve glides slightly with each step. When you lie down at night, perfectly still, blood pressure slightly lowered by sleep, the natural movement-driven circulation in the lower limb essentially stopped, the nerve loses even that minimal support. The already compromised blood supply drops further. The sensory deprivation deepens, and the nerve, which has been oscillating between over-signaling and under-signaling all day, tips further into hyperexcitability. The burning intensifies precisely when you are most still. This is why passive rest is not a strategy for neuropathy. The nerve needs its environment maintained actively through movement, circulation, sensory input, and mechanical mobilization every day. The 6 movements in this protocol are not a cure. They are a maintenance system for the environment the nerve depends on. And like all maintenance, the result is not dramatic overnight change. It is the prevention of further deterioration, followed gradually by measurable functional improvement in patients who are consistent. 20 minutes daily. All 6 movements sequenced. Activation first, sensory and circulation work in the middle, nerve mobilization last when the tissue is warm. Neuropathy responds to layered, consistent, targeted attention. Not to any single intervention, not to rest alone, and not to medication alone. Each of these 6 movements addresses a different reason your nerves are struggling. The arch activation rebuilds the structural housing of your nerve endings. The ankle alphabet pumps circulation through the tarsal tunnel. The sensory stimulation walk maintains the pathways going quiet. The nerve glide restores the nerve's own mobility through the lower limb. The toe exercises stimulate the small fiber nerve endings directly. And the balance work preserves the proprioceptive system before it becomes a fall risk. Begin with whichever one feels most accessible today. Add another tomorrow. By the end of the week, you have the full protocol. Tell me in the comments, which symptom is most affecting your life right now? The burning, the numbness, or the balance? I read every comment, and I want to understand what you are dealing with. If someone you know is managing neuropathy, share this video with them. This information should not be hard to find. I am Dr. Hameed Ullah Shaheen. Thank you for watching.